Hello, welcome, and thank you for joining us today. My name is Betsy Ballack, and I am a partner on the health law team at Smith Amundsen in our Chicago office. I'm joined today by Jennifer Stewart, who is also a partner on the health law team in Chicago, and Susanna Overholt, who is a health law team partner at our Indianapolis office. We're going to spend maybe an hour or so today talking about the impact of COVID-19 in the long-term care setting. So without further ado, let me go to our agenda for today. So here's the things we are going to kind of try to run through. I'm going to start, and I'm going to give you a little bit of an overview sort of the state of the nation as to COVID and long-term care. We will not belabor those issues. I will also touch on regulatory impact and potential litigation issues. Then I'm going to turn it over to Jen and Susanna for the heavy lifting. Jen's going to talk about immunity laws and some other protections, and Susanna is going to speak about concerns related to employees. So I'm going to go ahead and get started. I feel like you can't turn on the TV these days without getting some more numbers. So I'm going to give you a couple, but we're not going to spend a whole lot of time on this. Here's where we are as of literally about 20 minutes ago. I updated it. The numbers changed since I made these slides on the 14th. Today is the 15th, and we have new numbers. So 4.5 worldwide cases, 1.43 million cases in the US. And I think that third bullet there is probably the most relevant and the most interesting for our conversation today. The numbers, at least as of the 14th, were suggesting that about 30% of the cases in the United States, the deaths in the United States that are COVID related, were related to or were found in the long-term care nursing home setting, either for the residents or for the workers. So we know that the numbers are big, and I don't think we need to spend any more time really belaboring that point. It's different by state, and we know that as well. The states that Jen and Susanna and I represent are running about 40%. Some of the states on the East Coast, those numbers are a bit higher. Obviously, some other states are a bit lower to get us to 30%, but the numbers are big. And so, so I think we have to start the discussion. Oh, I want to show you one more slide first, though. So this slide is actually from Connecticut, and it's for the second 2 weeks in April. The orange line that's sort of looking like it's extending to the right there represents the deaths in the general population in the state over that period of time. But look at the blue line, right? So the blue line, at the time, deaths in the general population were plateauing. Deaths in the nursing home population there were still on the rise. So we know the numbers are big, and I think all of us feel that fairly acutely. And then if that wasn't bad enough, we've added a couple other players to the game, and here they are. So the media and politicians, and again, you can just jump on the internet and find 1,000 stories about places that are really struggling. I do think it's interesting, we politicize this to a degree. This was the first bullet there is a campus in Illinois. And the newspaper quoted the mayor of that town as saying that this particular nursing home that was having the trouble was, quote, a mess, which is not particularly supportive. The next couple of bullets talk about the reporting of the regulatory reviews. So the first one there, the 89% of nursing homes have been cited for infection control violations in the past. That's in Illinois. And then the one in Maryland talks about fines levied against a particular nursing home that was having difficulty. So people who work in long-term care and understand a little bit about the regulatory process may not be as sort of stunned by those numbers as the general public might be. But clearly, from the consumer's perspective, some of these numbers are eye poppers and a little bit stunning if you're not familiar with how the numbers are generated. The last bullet there I thought was sort of interesting. So this is an epidemiologist, I think he was out on the East Coast, talking to his state politicians. And here's his quote. This brings tears to everyone's eyes. Our nursing home population is like princess diamonds that need to be protected. I'm going to be honest with you, I don't really know what Princess Diamonds are. I apparently don't travel in the diamond circle enough, but they're clearly something that we cherish, that he wants to protect. And I think most people who work in this setting, when seeing a quote like that, probably think to themselves, where have you been? Where have you been for the last 5 or 10 years where I've been working to try and gather resources for the folks I see every day that I've dedicated my career to trying to help. So for good or ill, it's getting people's attention about the vulnerability of this population. It does kind of beg the question, which may seem like a no-brainer at first, but to think about, why is this particular setting, these particular people, why are they so vulnerable? And I'd like to talk through just a couple of thoughts on that. On the left-hand side, first category is the residents themselves. This, again, preaching to the choir, this is what you all know every day: elderly, comorbidities. I think the dementia issue is particularly difficult with the current issue, because obviously people with dementia don't have the ability to follow your infection prevention instructions, and that's a problem. So that's a tough one. The other thing that I found interesting, and I don't know if all of you have had a chance to see and review the New England Journal of Medicine article that came out at the end of April, partially authored by someone from the CDC, and they reviewed that initial outbreak at the nursing home in Washington State. And in that article, they conclude that elderly people, because of their immune system, coupled with their age and their comorbidities, they present in an atypical fashion. They have a different presentation of symptoms, signs and symptoms related to flu-like diseases. So there's another problem, is that if we're looking for fever, and this particular patient population does not present with fever, then we may miss some folks who had early symptoms and we didn't know it. So I think residents, that's pretty easy. They're a very fragile population. The next one I want to talk about just a little bit is sort of the nature of the business, right? So I would say that far and away, I think the majority of residents who you have who come to your facility, specifically if they're coming for short-term rehab as a Medicare stay, they're coming from an acute care facility. And even though we always say in the litigation side, and all of us are involved in defending hospitals and providers in both the long-term care and the acute care setting, in litigation, medical negligence litigation, we always tell people that the difficult time is during transitions of care to and from the hospital, from the hospital to home with home health, whatever the transition is. There's a lot of opportunities for missed handoffs or missing a piece of information that's critical to care for that particular resident or patient, depending. So here we've added another layer because most of our patients who come in become residents as transfer. And then also, if you're a CCRC and have multiple levels of care, your residents on campus may move from residential living to come in for a short stay in your skilled facility after a knee replacement, for example. The point is that every time we transfer residents, these frail residents, from one location to another, we have created another opportunity for them to be exposed to new people and potentially exposed to additional infectious diseases. That's on top of the regular issues related to transfers generally. Obviously, our folks stay with us for a long time. If they're in the long-term care setting, that can also confound it. Another issue is the facilities themselves. So some of our facilities are just beautiful and lots of room, very spacious, the newer facilities perhaps. We do work with some facilities that are maybe serving under or in areas that are underserved, and they've taken and repurposed older buildings that they're now using as long-term care campuses, and they've done a great job, but there's just not as much space. So now you have people who are in close quarters, and of course that increases the risks for infectious disease. The last one is one you may not have thought about quite as much, but many of the folks that we work with outsource some of their specialty disciplines, and I've listed some there. And so those folks, like for example, perhaps a nurse practitioner who sees some of your residents may also see patients in a clinic or in a hospital setting. So you have the clinicians may also be moving to multiple facilities. And anytime you have someone where you've outsourced their employment, you lose some element of control. What are they doing at the other place in terms of PPE and infection control? Are they following your policies? How can you work with them if they're not? So I think the nature of the business and the players in the game contribute to that. But there's more. So the other issue is potentially our staff people. We know turnover can be an issue, just generally, but also having interviewed lots and lots of staff people who work in the long-term care setting, many of these folks have more than one job. And so then the question is, what are they doing at that other job? And what are they doing in terms of PPE? And are they being as careful there as we feel we're being here? Agency use and funding issues are, chronic problems in healthcare, period, but you have to train every agency person who comes in. And again, that creates additional risk for us in terms of COVID transmission. The last thing about staff, I think, is that staffing numbers, which may have seemed perfectly adequate before, may feel less adequate now since the onset of COVID. And in some way that may be due to the restriction on others coming into the campus. Families certainly can at times be a hindrance to care, but they can also be a huge help. And they may take mom for a walk or help give someone a bath or feed them. And then also the volunteers, of course. So we've lost some of the hands who were there to help us, and those tasks are now falling to our staff people who may be a little overstretched and not able to take the time to follow your infection control policies specifically. And just donning and doffing PPE takes time. So if I'm going to go in a room just to hand a resident her glasses, she put on her call light and wanted me to do that, I have to don all the equipment, do what I'm going to do, and then come back out. And of course, all of that takes time. The last sort of issue that I think makes us at greater risk, which may seem a little less obvious, but is the next column, which is sort of the regulations and the reporting requirements. I said to someone I was working with, 6 months ago, you probably remember that you were concerned about planning your staff Christmas party and worrying about staffing over the holidays. And those problems now probably seem mundane because let's face it, almost all administrators are spending at least some time or have delegated to someone the job of staying up to date with the latest CDC regulations and the latest reporting requirements. And that's got to be done. That takes time. And then the reporting itself. And that's very cumbersome. We'll talk about that a little bit more in a bit. So the burden on the administrative staff who might have been able to help out in other cases has shifted to a degree. So all of these things are pieces that have made this particular setting, I think, a little more at risk for some of these infection control issues. While we're talking about regulations, I just want to put in one quick thought about strike teams. So I don't know about you, but when I first heard the term strike team, it sounds so terribly paramilitary that it sort of struck fear in the heart. I think the jury's still out, and it's unfortunate that we can't interact because I'd like to know if anybody has experienced having them come in yet. But they have been employed in a number of states. They're health officials, as listed here, but also clinical people, nurses, phlebotomists, a variety of other types of clinicians. And then in some cases, they include National Guard members who are there to help in any way they can for campuses that need that help. So why are they there? Well, it depends on which governor told them to go, right? So it's different and it's across the board. So some are to assist. Some are, the second bullet is from Illinois. It's to analyze and see what can be learned, which sounds like language that is really saying we're going to investigate and find out where you messed up. I don't know that, but it does sound like that to me a bit. There are some teams that have come in and said, that's it, we're testing all your residents and your staff right now. And we'll talk more about that later as well. And then others are simply going in to observe. So these people who come in the strike teams may be an additional thing that you have to consider in your day as you go through to care for these patients. Surely one thing that is going to come out of this, seem to be missing once. There we are. Sorry, wrong slide, but there it is. I wanted to talk about some heightened scrutiny related to infection control. In looking at the numbers from last year, and regarding infectious disease generally, the F tags for infection control and prevention were issued more than any other F tag nationally when you look at all of the numbers. So infection control was already on the radar of the agencies who are looking at that. 35% of providers were cited for infection control deficiencies. So it was already there. Now, fast forward, now we're in 2020, and CMS has said that they will order some campuses to be surveyed, certainly about IJs, which are listed here. But I do think the second bullet is a little interesting. They also are going to come in to facilities where there have been complaints about infection control concerns. And we'll talk a little bit more about the interactions with family. The other piece I wanted to talk about, which I gave you a little preview of here, but here's another thing that is potentially coming next. So do we think these cases are going to be litigated in the sort of medical malpractice world? Well, we know so far that there have been employment cases, and this first one here is a little bit of a one-off case, but it's kind of interesting. It was a filed action. This was in Illinois as well. A particular campus had 200 cases, and they had been cited a number of times and still failed to instruct their staff to use proper PPE. And so the town in which this particular facility is located is not Chicago. They went into court and got a temporary restraining order entered against the campus, mandating that they comply with these rules. So those kinds of actions are, of course, only going to increase the scrutiny by the government and other agencies that do that kind of work. But what about straight medical negligence or statutory violation cases related to long-term care? So we've certainly seen lots of campuses that are getting requests for records from families. Maybe that they're working with attorneys, but we also, we keep an eye on sort of the big players in litigation, at least in our area. And one of the big local firms, they initially seemed to be sort of cheerleading on their website. They were talking about thank you first responders and the like. There's been a little shift now, and I just put some snippets here, but that they're advocates and they're ready to help, and they want to ensure that your loved one stay safe and healthy. Feel free to give us a call. Immediately below that language is a link to the names of all the nursing homes in Illinois that have at least one confirmed case. So is litigation coming? I think it's probably a good bet that litigation is going to come, and Jen will talk a little bit more in just a second about some of the things we can do to help prevent that from the statutory point of view. So now that I've got my slides back in order here. So the other thing is we're talking about more things that are coming for long-term care as this process sort of evolves. There's going to be additional reporting requirements, and CMS just on May 6th put out a new set of guidance. There's going to be an additional way in which they want campuses to report. It sure feels like some of it is redundant with the work that's being done with state and county agencies, but they clearly address that in the guidance and say that it is complementary to and not redundant with that information. I guess that's still, we'll see if that turns out to be the case. There's some criteria for when you're due to report, single case or a cluster. The tricky bit is it's got to be done by 5 p.m. the following day. And so that creates trouble for folks, this includes weekends. So these things need to be reported pretty quickly. With that guidance, they include some focused survey guidance specific to infection control, which may be helpful. And there is a grace period, which we're right in the middle of right now. I think it goes till May the 24th. After that, they will start to look at campuses that have not reported any cases. And if there are cases that have not been reported, those can, in fact, result in civil monetary penalties. So we talked about we're vulnerable, the numbers aren't so good, and we talked about the media, which is not super helpful, and then all this regulatory stuff about the reporting and about the potential for litigation. And one more little bit of I think not unknown news, but not particularly happy news. It certainly seems as of right now that the people who are smart enough to know, like the CDC director, think that COVID will make another appearance in the fall. He thinks it would be more devastating. The Harvard guy who is working with the federal government said it will be back, and it will be very similar to the wave that we have just gone through. So this little guy is sitting here at the bottom of the screen looking pretty glum, and the truth is that I don't think it's all gloom and doom at this point, and I want to run through a couple of reasons why not. So first of all, I've personally spoken to a number of county employees and investigators who've worked with campuses I'm involved with. And I'm told that the state folks are also like-minded and being, at this point, supportive, collegial, and trying to give advice and give support versus being punitive. So hopefully that will continue. Our guy with the princess diamonds may be an example of recognition that this is a tough job, that these are people who need a lot of support. Individual state agencies and county agencies actually can provide additional resources specifically in terms of PPE, though possibly also in terms of staffing, depending on the issues. And then again, the immunity orders and some other protections that Jen will give you more information about in just a second. So that's kind of the end of my thoughts about setting the table for the others. I just want to kind of return to what I think are the important pieces for everyone to think about. Number one, it's probably coming back. Number two, there are resources out there, and I would encourage you to access those resources now. So know the names of the county people who are your go-to for PPE supplies, for example, if you need them, or sometimes just for maybe a medical consultant with your county epidemiologist. The other consultants are there. You might consider retaining a media consultant, depending on the number of cases you have and the area in which you live. You might consider retaining an attorney. You might consider an infection control or infection preventionist person, infectious control doctor, whatever, an infectious disease doctor rather, whatever it is you need to help you get through, you should start looking for those resources now. The reason why I think that's very important is that I think everybody, though it may not feel like it, I think everybody has gotten a little bit of a get out of jail free card with this first round, because clearly this took the whole world and certainly the United States a little bit by surprise. So I think people are trying to be helpful at this point. If COVID returns in the fall, I'm not sure that we will see the same forgiving nature from the regulators and the surveyors. So now is the time. So if you need to do work on your campus, set aside isolation rooms for what may come in the fall, change your structure, put in reverse flow air filters if you need to, stockpile PPE, or at least find out where you can quickly access that PPE, and then have consultants ready to go. I think now is the time to do that work, as hopefully we're starting to catch our breath a little bit on some of these other issues. My last point really is just something that we talk to all our clients about, but certainly applicable to this care setting as well, and that's preparing for litigation. So, you may have an idea about what you think your system is for, managing care, for dispensing medications, for PPE, for infection control, for any of those issues. As a person who has helped present many staff nurses and CNAs for deposition, your staff doesn't always know what those issues are or what your plan is or how exactly that works. So educate your staff specifically on PPE and then and COVID generally, and then retain those documents. So, all those sign-in sheets, the handouts, the topics, all of those pieces, I would start a COVID file and make sure that somebody who is there knows where that is. So if a state surveyor comes in, you can easily put your fingers on that. Next thing is to keep your process simple. By that, I mean that if you're going to do extra things for COVID that you have not done before, fine, but try and use the systems that you have in place. Use your EMR to enter that information, whatever additional data you're collecting, but don't make it so complicated, number one, that your staff doesn't get it, or number two, that you can't remember 2 years from now what your process was. And then the last thing, obviously, big letters, communication and transparency. There's a lot of stories in the media about families feeling very vulnerable because they can't do what they used to do. They can't come in and eyeball their loved one to see that they look okay. And that's very, makes a person feel very helpless. So people who feel frustrated and anxious and helpless turn into potential plaintiffs very quickly. So communicate with your families. You're mandated to anyway, but make sure you're doing everything you can. Use all the cool tech you can think of, or the balcony yelling sessions or the window sessions, whatever it is, so that they feel like they're still connected, and be transparent when you have cases that have come into your facility. So that's sort of the end of my part of the remarks, and I will now turn it over to Jen Stewart.
Thank you, Betsy. Now, given what Betsy just told us, it's clear that long-term care facilities are already targets for litigation as a result of the COVID-19 pandemic. So what kinds of protections do long-term care facilities and their staff have against these kind of lawsuits? So that's what we're going to look at now. Next slide. So there are several federal statutes that provide some relief to healthcare providers, including providers at long-term care facilities. And one thing to mention about all of the immunities we're going to be talking about today, these immunities only apply if the caregiver or the facility is working in good faith. And the cutoff for where that good faith ends really varies from statute to statute and from state to state. But generally, the statutes will not provide immunity for conduct that is grossly negligent, willful or wanton or intentional, or if the conduct occurred while the caregiver was under the influence of drugs and alcohol. Next slide. So the Federal Volunteer Protection Act of 1997 was intended to promote volunteerism by limiting and in many cases completely eliminating a volunteer's risk of tort liability when they are acting on behalf of a nonprofit organization or government entities. So for any of you working at not-for-profit facilities, this is a statute that may provide some protection to your volunteers during the pandemic, whether they are, layperson volunteers, there to just spend time with residents, or if they're even, nurses and physicians who are volunteering their services. Next slide. Next slide. Thanks. So the Public Readiness and Emergency Preparedness Act, or the PrEP Act, provides broad immunity protections to healthcare professionals who administer or use countermeasures that are covered by declarations issued by the HHS Secretary. So on March 17th of this year, HHS Secretary Alex Azar issued such a declaration, and he applied immunity protections to physicians and other healthcare professionals who administer or use countermeasures specifically for COVID-19. Those countermeasures are things like antiviral medications, other drugs or biologics or vaccines, diagnostic tools or devices, and really anything used to treat, diagnose, cure, prevent, or mitigate COVID-19 or its transmission. Next slide. Now, the federal law does provide an avenue for claims of negligence related to the administration or use of these COVID-19 covered countermeasures. So even if an individual is injured, even if they are not able to sue their healthcare provider, what they do have is this countermeasures injury compensation program that was set up and authorized by the Public Health Service Act. Now, it's a very high bar to meet for a plaintiff to receive funds from this program. They have to provide what they consider to be compelling, reliable, and valid medical and scientific evidence to prove a direct causation link between the covered countermeasure and the serious physical injury or death. And, you know, we heard about some suits from Betsy here, the image you see on the right side of the slide. This is just an example of advertising that plaintiffs' attorneys are already putting out there in response to the PrEP Act's immunity provisions. Next slide. Now, the Federal CARES Act, the Coronavirus Aid, Relief, and Economic Security Act, clarifies that physicians and other healthcare professionals who provide volunteer medical services during the public health emergency related to COVID-19 shall not be liable for providing services, again, relating to the diagnosis, prevention, or treatment of the condition, or for their assessments or care of patients who are suspected to perhaps have COVID-19. Next slide. So on March 24th of this year, the HHS Secretary issued a letter urging all state governors to take a number of actions, including to provide civil immunity from medical liability on a state-by-state level for healthcare professionals treating COVID-19. You know, so there is a recognition at the federal level that these immunities we've talked about so far primarily apply to volunteers. That's not much help to all of the staff at your facility who are licensed professionals. But we're going to see what the states did in response. Next slide. So in terms of state action, we have really seen kind of an evolving approach for how states are establishing immunities for their healthcare providers over the last couple of months. Since mid-March of this year, and I'll let you know that these stats I'm about to give you are accurate as of May 15th, 2020, but I'm sure as with the numbers Betsy gave you, they're going to change quickly. But since mid-March of this year, 16 states have issued executive orders on the topic of healthcare provider immunities. 3 states have enacted legislation, and 4 states have done both. Additionally, there are some states that had existing legislation that was already in place and immediately and automatically became effective once there was an emergency declaration within that state. You know, other states issued guidance or executive orders that specifically confirm that pre-existing statutory immunities are applicable to providers to protect them from liability for care rendered in connection with the COVID-19 pandemic. And we're going to talk about 3 kinds of state immunities. So first, the Good Samaritan statutes, which I think we're all at least somewhat familiar with. The second thing is statutes that automatically provide immunities during a declared emergency. And then third, the immunities that require additional action beyond just a declaration of emergency before they actually provide protection to healthcare providers. Next slide. So one existing immunity protection is Good Samaritan statutes. All 50 states have some form of the statute. In Illinois, the statute protects licensed medical professionals who in good faith provide emergency care without fee, again, except for willful or wanton misconduct. In Indiana, the law states that a person who comes upon the scene of an emergency or accident and who in good faith gratuitously renders emergency care is immune from civil liability. Similar to Illinois, the protection stands unless the Good Samaritan's actions amount to willful or wanton misconduct or gross negligence. And under Wisconsin law, any person who in good faith renders emergency care at the scene of an emergency or accident is immune from civil liability and rendering the emergency care. However, the immunity provided by Wisconsin's law, it does not apply when employees trained in healthcare or healthcare professionals are rendering emergency care for compensation and within the scope of their practice at like a hospital or the scene of an accident or a physician's office. So in other words, in Wisconsin, if you're a healthcare professional on duty providing emergency care, this immunity is not going to apply to you. So again, it's really limited to the gratuitous giving of care. Next slide. So for statutes that were already in place and providing some level of immunity to healthcare providers, including long-term care providers, in Illinois, there is the Emergency Management Act. This provides immunity to healthcare facilities, providers, volunteers, from civil liability for injury or death that is alleged to have been caused by any act or omission during the pendency of the governor's disaster proclamation. And the injury or death has to occur at a time when the healthcare facility provider or volunteer was engaged in the course of rendering assistance to the state. That's a term of art, but basically, if you're providing healthcare services in response to COVID-19, this is a really good immunity that can and does apply to long-term care facilities. Next slide. Now, Indiana also has an emergency immunity provision that was already in place before the COVID-19 disaster hit us. Indiana's statute provides that a person can't be held liable for the care they provide in response to a declared disaster emergency if certain conditions are met. And an interesting thing about Indiana's statute is that the immunity applies regardless of whether the actual provision of healthcare services occurred before or after the declaration of a disaster emergency. And as we just saw, Illinois statute is only for the pendency of the governor's emergency declaration, or in some cases, 60 days beyond that. So the Indiana protections are a little bit broader. Next slide. Now, the criteria for Indiana healthcare providers to meet in order for the immunity to be in effect, first, you have to have an Indiana license, and second, you have to be providing healthcare services at a location that has been declared a disaster. So you're going to have to be in the disaster area and licensed by the state. Next slide. Indiana statute also protects facilities as well as individual healthcare providers and basically offers the same immunities to the facilities as it does to the individuals. Next slide. So what about specifically COVID-19 immunity provisions? Illinois, Indiana, and Wisconsin have all issued, well, they've each done something a little different. Illinois has an executive order. Indiana just issued guidance from the State Department of Health, and Wisconsin enacted legislation. So we're going to take a quick look at those. Next slide. So Illinois' Executive Order 2020-19 confirms that healthcare facilities, professionals, and volunteers are immune from civil liability for any injury or death under the immunity provided by the Emergency Management Act, which we spoke about briefly, the Emergency Medical Services Systems Act, and the Good Samaritan Act. So here, the immunity is going to exist unless injuries were caused by gross negligence or willful misconduct. And the facilities encompassed by this order specifically include a really wide swath of healthcare facilities including facilities licensed by the Illinois Nursing Home Care Act, and other facilities, residential facilities catering to the developmentally disabled. So this is a very good protection to have in place for Illinois long-term care facilities. The order does not specifically address things like assisted living facilities, so there are some questions about the immunities and whether they go far enough, and there is still some talk about expanding them within the state of Illinois. Next slide. So on April 3rd of this year, the Indiana State Department of Health issued guidelines for facilities and individuals who are providing healthcare services in response to a declared disaster or a declared emergency, such as the current COVID-19 emergency. The guidance here really is kind of a reminder of what the existing Indiana law and federal laws are that we looked at earlier. One criticism of Indiana's guidance is that it's not clear whether the immunity is limited strictly to the diagnosis, treatment, and care of individuals with COVID-19, or if it extends more broadly to some or all medical services provided during the emergency period, regardless of what that treatment was for. So in Illinois, for example, the executive order we just talked about specified that things like postponements or cancellations of non-emergent procedures are covered under the immunities, as was treatment of non-COVID patients whose care has been impacted by the pandemic's effect on things like hospital staffing, hospital supplies, hospital scheduling. This is, one thing that Illinois is a little bit ahead of Indiana on. But again, there is a very healthy debate going on in both states about whether or not these should be extended further. Next slide. So Wisconsin enacted Act 185 on April 15th of this year. And Act 185 provides immunity from civil liability to healthcare professionals and providers, as well as their agents, employees, and contractors for any accidents and omissions resulting in death or personal injury. The conditions that are required for this immunity in Wisconsin are, first of all, the care has to occur within the time period of the state of emergency declaration, or within 60 days after that declaration ends. The care at issue has to be consistent with any direction or guidance or recommendations that were made by federal, state, or local officials, or formal guidance from the Wisconsin State Department of Health or HHS. And again, the actions, if you've got reckless, wanton, or intentional misconduct, the immunity is not going to extend to that. One thing that's notable about Wisconsin statute is that it has a very expansive definition of healthcare professionals and providers. So beyond physicians and nurses, the statute also specifically provides these protections to dentists, to pharmacists, social workers, and even EMTs. Next slide. So in terms of things that we should be on the lookout for, some issues that plaintiffs' attorneys may try to use to get around the immunities are things like the constitutionality of the immunity itself. So is the plaintiff being deprived of the right to sue or the right to be made whole? Many states also have poorly defined distinctions in their case law between what constitutes gross negligence versus willful and wanton behavior versus just willful or just wanton. Plaintiff is going to want to expand the definitions of each of those categories and really have ordinary negligence be defined very narrowly. So even hinting of care that was higher than negligent would defeat the immunity from their perspective. Additionally, where statutes reference licensed caregivers, plaintiffs are going to be looking at what kinds of things can they plead against unlicensed caregivers and staff. So are they going to start coming after individual CNAs more in order to bring the facility into a suit? Additionally, they're going to be challenging the time periods for immunities. We saw that some only apply during the disaster declaration, some apply before and after. Again, plaintiffs are going to want to construe this time period very narrowly. So in a state like Illinois, where we have had multiple disaster declarations, there's likely going to be challenges as to which disaster declaration applies to a specific incident. But these are some of the things that I think we should expect to see them trying to pull out of their hats. And with that, I will pass the virtual mic to Susanna.
Thank you, Jen. I appreciate it. And hello, everyone. We're going to transition now to talk about kind of another area of risk for you to be thinking about, which is employee issues related to COVID-19. Next slide. So one of the things that has been interesting about COVID-19 is that there's guidance out there that allows employers to do things slightly differently than they would be able to normally. The EEOC, CDC, and OSHA have all provided guidance regarding actions they should be taking, employers should be taking with respect to their employees to mitigate the spread of COVID-19. And one of the things is that the EEOC is permitting temperature and symptom checks of employees. And these would normally be considered, medical inquiries that are not usually permitted by the ADA, but because of the nature of the pandemic, the disease is perceived as posing a direct threat to others' health, and therefore the testing is generally deemed to be job-related and consistent with business necessity, which is usually what the ADA is looking for to allow this type of testing and screening to occur. And all of these entities, again, the EEOC, CDC, and OSHA, are issuing specific guidance and requirements for healthcare employers. So employers generally, but specifically for healthcare employers as well. Next slide. So under the EEOC's guidance, employers may ask employees if they're experiencing symptoms of COVID-19. Now, the recommendation would be that you use the CDC recognized symptoms, which are on the CDC website. And at the end of this presentation, we've got a list of resources with links to pertinent websites that we've mentioned during this presentation. So one of these is the one that lists the symptoms, and those symptoms have actually changed since the outbreak began, and they continue to change as we learn more about COVID-19. So you should develop screening tools, but make sure that they keep up to date with what the current symptoms are. As I said, you can measure employees' body temperature, but also take note of the fact that not all individuals with COVID-19 have a fever, so that's not the only thing you should be looking for. The EEOC and CDC both clearly recommend that you require employees who have symptoms with COVID-19 to leave work. And I shouldn't say recommend, the CDC is mandating that you do that. And you may test employees for COVID-19 before you permit them to enter the workplace, and you can take action against them if they refuse to undergo such a test. Next slide. So the CDC has issued specific guidance for long-term care facilities so that would apply to your campuses. And these recommendations, or I should say guidance, is consistent with what had been recommended for all employers before the outbreak was widespread. But since that time, the CDC, as I said, has come out with specific guidance for skilled nursing facilities. So first would be to implement sick leave policies that are not punitive. They should be flexible. They should be consistent with the public health policies so that they would allow ill healthcare professionals to stay at home. Now, at this point in time, presumably you all have implemented policies like this and you're aware of this guidance, but we just want to make sure, that you keep it front of mind and keep looking at it to make sure you've done what you need to do under this guidance. So another point is to determine which of your personnel are non-essential and whose services can be delayed. Restrict non-essential healthcare personnel from entering the building. I think everyone has pretty much done that so far. And consider implementing telehealth for remote access to care activities. Maybe not everything needs to be done in person. Maybe telehealth works. Next slide. So healthcare professionals, not surprisingly, should wear a face mask or cloth face covering at all times when they are in your buildings. Face masks are preferred for healthcare professionals. Cloth face coverings should not be worn instead of a respirator or a face mask if more than source control is required. And I know that there's concern about a shortage of respirators, and we're going to talk about that in a little bit. All healthcare professionals should practice social distancing when they're in break rooms or common areas. Next slide. Another component of the guidance has to do with symptom monitoring. So healthcare professionals, including consultants and ancillary staff, should monitor themselves for fever and symptoms. And you should develop policies requiring that your employees and consultants and staff do this, and make it a clear expectation. Healthcare professionals should stay home when they're ill, and if someone develops a fever that is equal to or greater than 100 degrees, or if they develop other symptoms of COVID-19 while they're at work, they should leave the workplace immediately. And any individual who has suspected COVID-19 should be prioritized for testing. Next slide. Now, when it comes to screening, you should make sure that you notify your employees of the screening measures that you're going to follow well in advance, and inform them that the purpose of the screening is solely to protect them by keeping individuals with symptoms that are consistent with COVID-19 off-site, and that the screening is not to determine if an employee has any other illness. That's important under the ADA. The other thing to make really clear is that the screening is not a substitute for a clinical diagnosis and doesn't constitute a clinical diagnosis. So that being said, you should be screening your healthcare professionals and actually all your employees at the beginning of their shifts for fever and symptoms. Take their temperatures and document the presence or absence of symptoms. So that would be whether they've got a fever, again, of 100 or higher, or if they're feeling feverish, if they've got shortness of breath, cough, sore throat, muscle aches. And on the next slide, we're going to talk about some other symptoms as well. But a healthcare professional with any of these symptoms should be sent home and seek medical care and not return until they haven't had any symptoms for 72 hours and it's been 10 days since the onset of symptoms, or if they're instructed otherwise by a local health department or another healthcare provider. Now, one thing, well, actually, let's go to the next slide. I was about to get ahead of myself. Let's go to the next slide. So the other symptoms of COVID-19, which you've probably heard about recently, are nausea, vomiting, diarrhea, abdominal pain, headaches, runny nose, fatigue. There's also the new loss of the sense of taste or smell. If we would recommend that in the CDC as well, if you have employees who express any of those symptoms, they should also be told to leave the workplace, and those should be included in your regular screening. Now, the health departments, we've been having experience with the health departments getting pretty actively involved in monitoring COVID-19 in workforces. Some of you have maybe had to deal with local health departments during this period of time. The health departments have broad authority in preventing the spread of infectious diseases, which is what COVID-19 is. So you may have the health department tell you that employee has to be off for 14 days, or then, you know, because they're either positive or they've had close contact with someone who's positive. You should follow whatever the health department tells you from that perspective. And if you have questions, feel free to contact counsel to talk that through. But generally speaking, you should follow the instructions of the health department. Next slide. So OSHA has also been playing a role in COVID-19. You know, obviously, you all know that every day you have OSHA standards, requirements, you know, regulations that apply to you, and those continue to apply. This slide mentions some of them. Next slide. But OSHA has also provided some specific guidance for the pandemic that cover different aspects of the operations on your campuses. So for engineering controls, and again, these are the types of things that hopefully you have already considered, have already implemented, but we wanted to make sure to get them in front of you again, so you've got them and you can refer to them and kind of double check actions you've taken. But the OSHA is recommending that you shield healthcare workers, patients, and visitors from individuals with suspected or confirmed COVID-19, using, you know, things such as physical barriers or partitions, curtains, and the airborne infection isolation rooms. Next slide. Now, for administrative controls, again, these shouldn't be too much of a surprise, but isolating patients with suspected or confirmed COVID-19 to prevent transmission, and then also to isolate suspected cases from confirmed cases, just in case you've got a suspected case that turns out not to be a confirmed case. Restrict the number of personnel entering the room of a patient with suspected or confirmed COVID-19. And then train healthcare workers in appropriate use of PPE so they can perform tasks they usually don't perform, such as housekeeping, meal service, so that, again, you're minimizing the number of individuals, number of workers who are needing to enter that residence room. Next slide. So in addition, there are CDC guidelines about signs, you know, and labeling patient room doors when transmission-based precautions are in place. Make sure you're following those. And then when you're performing aerosol generating procedures, CPR, intubation, try to minimize the number of staff that are present at that time. Next slide. So for safe work practices, again, still coming from OSHA, perform as many tasks as possible in areas away from a patient with COVID-19. So, you know, if you're charting, don't stay in an isolation room to chart. Consider using closed-circuit television to communicate with patients. This should be a normal practice, but bears repeating, work from clean to dirty and limit opportunities for touch contamination. And then also prevent touch contamination by avoiding unnecessary touching of environmental surfaces with contaminated gloves. Next slide. PPE, something that has gotten a lot of attention, a focus of a lot of conversation. Obviously, healthcare workers have to use proper PPE when they're exposed to a patient who has suspected or confirmed COVID-19. OSHA recommends that healthcare workers with exposure to COVID-19 patients wear, shouldn't be surprised, gloves, gowns, eye and face protection, meaning goggles or a face shield, and then, you know, preferably, you know, certified disposable N95 respirators or better. Next slide. And the respiratory protection should be part of a comprehensive respiratory protection program that meets OSHA's requirements, and that includes medical exams, fit testing, and training. And when removing potentially contaminated PPE, such as a respirator, it's really important to make sure people do not touch the outside of the respirator without wearing gloves. Next slide. So what about the shortages? OSHA has adopted guidance addressing PPE shortages, especially the N95 respirators. And if there are shortages of any type of PPE, use of that PPE may be prioritized for high hazard activities. But workers do need respiratory protection when they're performing or present for those aerosol generating procedures I mentioned before, which would include CPR and intubation. And workers also have to be protected against exposure to the normal, bodily fluids, blood, other infectious materials, chemicals, and contaminated surfaces. So those are the important factors to bear in mind. Next slide. So OSHA's guidance has provided some, flexibility regarding respiratory protection, and there are specific circumstances where an N95 respirator is not available, and employers follow guidelines to conserve respirators. Employers can use certain alternatives, and OSHA is also providing enforcement discretion for annual fit testing requirements to help reduce the rate at which the respirators are used and discarded. Next slide. So those permissible alternatives are right here. So it's other approved respirators, and then other respirators that are beyond their manufacturer's recommended shelf life, so expired devices, and then certain respirators that are certified in accordance with standards for other countries. So those are permissible alternatives. And again, there's a link at the end of this presentation to the OSHA guidance, and I would recommend that you review that and follow the links if this is something you need to explore. Next slide. So OSHA inspections have also, will also be at play potentially on your campuses if there has been widespread, employee illness or resident illness. The fatalities and imminent danger exposures related to COVID-19 have been prioritized for inspections, and particular attention is being given to healthcare organizations. So that would mean all of you. And formal complaints alleging unprotected exposures to COVID-19 for workers with a high or very high risk of transmission may also warrant an on-site inspection, and healthcare workers are generally who are in direct contact with patients, residents who are positive for COVID-19 are deemed to be high and very high risk employees. Next slide. So if you end up in the heat of an OSHA inspection, which is probably something you aren't very familiar with, you should respond as you would for a survey inspection, which you probably are quite familiar with. So cooperate, try not to leave the inspectors alone, try to have a member of the management team present for interviews with staff. Granted, the inspector may not allow you to be present, but at least try. Notify counsel as soon as the inspector arrives, and keep copies of any documents you provide to the inspectors in a separate file so you've got ready access to whatever you provided. I mean, basically, this should be consistent with your protocol for a normal survey inspection, and I would just recommend that if you've got those protocols, maybe just follow those protocols for an OSHA inspection. Next slide. So OSHA reporting, that employers must record and report employee COVID-19 cases if the employee has a confirmed case and the case is work-related, and the case involves medical treatment beyond first aid, days away from work, hospitalization, or death. So you're likely having to deal with increased OSHA reporting. Next slide. The work-relatedness analysis is going to apply. So the injury or illness is work-related if the exposure, if an exposure in the work environment either caused or contributed to the condition, which is COVID-19. And work-relatedness is presumed for injuries and illnesses that result from events or exposures occurring in the work environment. And, you know, in the high-risk environment, it is, you know, there's going to be a real question about the work-relatedness, and, you know, there are oftentimes, I mean, one thing is to ask employees who end up testing positive about, you know, contacts with other people who tested positive, whether they've traveled, things like that, and we've, you know, we could provide you with a list of questions. But you know, just because one of your employees ends up testing positive doesn't mean that they got it at work. But given the high, if you have a campus with a high instance of COVID-19, you know, there's a chance that at least one of your employees will end up with a work-related exposure. Next slide. So there's obviously a lot to consider here. There's a lot going on, but you know, some of the primary points, you know, with respect to your workforce is that you may actively screen your employees for COVID-19 and should be doing that now. OSHA may be more present than usual. You should be prepared and react the same way you would for a survey. Take it as seriously, respond in a serious way. And lastly, follow OSHA and CDC guidance for conserving PPE and use of PPE and conserving it. And as I said, the next slide has a list of resources. It's got the resources links to the CDC, EEOC, and OSHA guidance that we've talked about. It also has a link to CMS guidance that Betsy mentioned. And finally, it has a link to our the survey we put together regarding state immunity laws. That's the conclusion of our presentation, and we really appreciate your listening. And if we can be of any assistance, please feel free to reach out to any of the three of us. And again, thank you for your time. Goodbye.